So now we start with the clubbing. What is clubbing? So clubbing means that there is the selective bulbous enlargement of the distal segment of the digits with the subsequent loss of the normal angle between the nail and the nail bed, and this part, that is the loss of the normal angle, I will explain subsequently. So there are many theories why clubbing occurs. So most accepted, or I could what I say that it is mostly the most important, I would say the most important theories includes the PDGF theory, that it states that the platelets platelets goes into the nail bed, and in the nail bed they release the PDGF, which is the platelet derived growth factors, and the vascular endothelial growth factors. These growth factors increases the permeability of the endothelium, and which causes the activation of the connective tissue cells like the fibroblast, and they release the factors which causes the proliferation of these cells. That is why the clubbing occurs. But there are some other theories, like the hypoxia theory is there, then we have the neurogenic theory is there, then we have also congenital clubbing theory also. So these are also the theory, but PDGF and hypoxia theories are important ones which you should remember for your Viva exams. So that is important. Now we come to the grades of the clubbing and how we examine the clubbing, that is very important. So the first is the grade 1, which is the increased fluctuation of the nail bed, which you examine in this way. This is the examiner's finger and this is the patient's finger, which you can see, and what we do, that we put our hand on the patient's hand in this manner, and then we press our this finger and this finger, press the patient's finger by our finger, and we check for the fluctuation. So if there is fluctuation, then it is a grade 1 clubbing. Now the second grade is the loss of the Lovibond angle, also called the onychonychial angle, and we also appreciate the Shamroth or the profile sign. So profile sign is basically the loss of the angle. So what is Lovibond angle or the coilonychial angle? Well, let me tell you. So as you can see, this is the nail, and this is the nail bed. So normally the nail bed, this is the line of the nail bed, and this is the line of the nail. So this is the less than 180 degree. But when there is clubbing, this becomes this like this, and this causes the increased Lovibond angle. So this is the case of the in the second grade, that is the loss of Lovibond angle, that is the Lovibond angle, right. So it is normally less than 180 degree, but upon the clubbing this becomes more than 180 degree. So more than 180 degree is seen in the clubbing, right. Then we have the Shamroth sign, that is the Shamroth window. What we ask the patient, that we tell the patient to make the finger like this, and upon making this we can see a small diamond shaped space, that is called the Shamroth's window, and if this window is present, then the patient is normal, and if it is absent, then this this is called Shamroth's sign, and this is a very important sign that this clubbing is present, right. Then we have the grade 3, which is called the parrot beaking or the drumstick fingers, and you can see here, you can see this is the you can appreciate that it is the parrot beaking or the drumstick. As you can see, this is just like a parrot's beak, right. So this is grade 3, and the grade 4 is the pain along the distal ends of the long bone due to subperiosteal bone formation. As I told you, this there is a release of the growth factors. So there is formation of the new bone that is causing the pain, and this is generally seen with bronchogenic carcinoma, right. So this is the grade 4. Now let us see what are the causes of the clubbing. In the exam you are not expected to answer all the causes, but most importantly you have to answer the very common ones, like this is the bronchogenic carcinoma, very important. Then we have the suppurative causes, right, like the bronchiectasis and lung abscess are very important. Then in the cases of the cardiac causes are very important, most importantly the cyanotic heart disease. Then we have the subacute bacterial endocarditis, and then we have the acyanotic disease with ASN mineralization. In the GIT, since GIT you cannot expect that GIT could have the causes for the clubbing, so this becomes very important, and most importantly seen in the inflammatory bowel diseases, that is the ulcerative colitis and the Crohn's disease. Hepatocellular carcinoma could also be important, but IBD is more important. In the neurological causes, you have the median nerve injury, hemiplegia and syringomyelia also. But most importantly, remember the cardiac cause, GIT cause and the malignancy and suppurative causes, they are the most important ones. Right, there is atypical presentations of clubbing, just as we discussed about the cyanosis. We have also the atypical presentations of the clubbing. For example, clubbing can be acute in case of lung abscess, empyema and the subacute bacterial endocarditis. There could be unilateral clubbing in case of hemiplegia, in case of Pankos tumor or in case of aneurysm of the subclavian artery. There could be pseudo clubbing as in case of leprosy, leukemic infiltration, hyperparathyroidism, thyroid acropathy. So these are the important ones. You can cannot choose to not remember these also. So few are the important ones. Then we have the painful clubbing seen in the lung abscess, subacute bacterial endocarditis and the bronchogenic carcinoma. Reversible clubbing is seen in the cases of lung abscess and empyema. Unidigital means in single finger, you can see in the median nerve or the trauma cases. Clubbing with cyanosis seen in congenital heart diseases, cyanotic ones. Differential clubbing and reverse differential clubbing, just like the cyanosis part, exactly the same. That is the in the upper limb it is normal, in the lower limb you see the clubbing. This is seen in PDA with reversal of the shunt, that is inside membranization. Reverse differential clubbing, just the opposite of the differential clubbing, upper limb has clubbing, lower limb is normal, seen in case of PDA with TGA plus Eastern membranization. This is the all about the clubbing. Along with clubbing, since we are talking about the clubbing, we will see some other nail changes that gives us an idea of what are the underlying conditions could be. For example, chylonychia seen in IDA, that is iron deficiency anemia, and let me give you the picture, that is the the chylonychia. You can see this spooning of the nail, that is seen in the iron deficiency anemia, and it can also be seen in hemochromatosis, but remember the iron deficiency anemia. Then we have the Buse lines. You can see this is the Buse lines. As you can see, this is called the Buse lines. The Buse lines are seen in measles, pneumonia and pulmonary infarction. Then we have the plumber's nail, right? Plumber's nails are there. As you can see, this is the plumber nails. Plumber nails are basically seen in the hyperthyroidism. Then we have red nails seen in congestive heart failure. You can see this is the red nails seen in the congestive heart failure. Then we have blue nails seen in copper or silver deposit. Then we have the black nails. This is the black nails seen in the Peutz-Jeghers syndrome, Cushing disease or Addison's disease. Then we have white nails. As you can see, these are the white nails. White nails are seen in case of anemia, hypoalbuminemia, diabetes mellitus, congestive cardiac failure, or it could be a case of rheumatoid arthritis. So these are the differentials when you see the nail changes, although they are not very much specific, but it does give you an idea most of the time what are the underlying conditions, and it could be asked in your viva, very frequently it is asked. So this was all about the cyanosis. So this was all about the clubbing, and we also discussed about the different nail changes. Now we will be discussing about the edema. So edema, what is edema? Edema is the abnormal accumulation of the fluid in the interstitium, and when we talk about the edema, there should be a very clear concept about what is the site of the examination of edema, because in patients we generally remember only about the medial malleolus, or we say that the dependent parts. But what are the dependent parts we need to know? First of all, if the patient is mobile, moving, then we can see the edema in the medial malleolus, above the medial malleolus 2 to 3 centimeter above the medial malleolus. So 2 to 3 centimeter in the leg above the medial malleolus is the site in the mobile patients. In a bedridden supine patient, we see it in the sacrum region and over the scapula in the back. And if we want to check for the abdominal wall edema, then we should look by pinching the skin over the edema, right? Now after that, we want to know what is the technique. So for that, we need to at least press the skin and the subcutaneous tissue for at least 15 to 20 seconds against a bony prominence, as like in the medial malleolus we check by pressing the skin above the medial malleolus 2 to 3 centimeter above the medial malleolus for 15 to 20 seconds, except for the abdominal wall edema, in which we pinch the skin, not press the skin, right? So this was the technique. Now coming to the grading of the pitting edema, I am talking specifically about the pitting edema, not about the non-pitting, because in non-pitting there is no pitting, so there is no depression, so we cannot tell what is the grade. So in the pitting edema, what are the grades? There is 1 plus, 2 plus, 3 and 4. So this is very easy to remember, just double the number here. So 1 multiplied by 2, so it is 2 millimeter depression, immediate rebound. 2 plus means 4 millimeter deep pit, 3 plus means 6 millimeter pit, and 4 plus means 8 millimeter deep pit. And this few second, 10 to 12 second and 20 seconds. So basically you remember this by just multiplying 2, or you can remember in that way. So this is the grading of the pitting edema. Now we classify the edema on the basis of being it pitting or non-pitting. So non-pitting is also known as brawny edema. So the pitting edema again divided into two types: rapid recovery or slow recovery. Rapid recovery means it recovers within 40 seconds, and slow means it takes more than 40 seconds. Rapid recovery, the mechanism is decreased oncotic pressure, basically means low serum protein, and the slow recovery, pitting edema is due to increased hydrostatic pressure, that is the proteins are normal but there is increased pressure. So the pitting edema rapid recovery type is most likely seen when there is low serum protein, and we know what are the different causes of low serum protein. First is there is loss of the protein, or it could be decreased intake or synthesis. So there is increased loss as in case of burns, bowel disease, and importantly the nephrotic syndrome. Then we have the decreased intake or synthesis causes like the kwashiorkor, liver disease, malabsorption. So these are the causes for the rapid recovery pitting edema. Now for the slow recovery pitting edema, we have causes where there is increased hydrostatic pressure like the congestive heart failure, pericarditis, tricuspid valve disease, and then we have the local venous causes like the deep venous thrombosis, inferior vena cava syndromes. These are the causes for the pitting edema of the slow recovery type. Now coming to the non-pitting edema, which do not pit or recover in few seconds, it is non-tender. Skin shows hyperkeratosis. What is the mechanism? The mechanism is lymphedema, that is the edema of the lymph vessels. The cause is the lymphatic obstruction causing the lymphedema. Now we have some causes. First cause is mixed edema, which is seen in the hypothyroidism. Then we have pretibial mixed edema, which is seen in the Graves disease, which is due to the deposition of the GAGs, that is the glycosaminoglycans, seen in the Graves disease. Then we have in the upper limb, it is due to breast cancer, or it could be radiation induced. In the lower limb, it is due to apraxia cutis. It could be congenital, like in the case of mixed disease, Precox, Tada, Milroy disease. Then in the phyllodes, very important, in the phyllodes we see lymphedema, that is the non-pitting edema. Then we have the streptococcal infections and malignancies. Along with it, we see facial edema in case of other diseases like the angioedema in case of Quincke's, which we also say Quincke's edema, then the nephrotic syndrome, then trichinosis, hypothyroidism and allergies. Neurogenic edema is the secondary due to autonomic functions. Then we have drug induced edema like the nifedipine, corticosteroids, estrogen, NSAIDs and insulin also. So these are the important classifications for the type of the edema and their causes. Now let us move on to the lymphadenopathy. Now coming to the most important, and I think it is basically very much important topic, and the students get feared about this topic because lymphadenopathy, when asked to examine the patient, becomes the most important and hard point for the students, because lymphadenopathy, checking it, examining it is very tough. So let me keep it very simple and easy for you. So let us start. What is generalized lymphadenopathy? What is generalized lymphadenopathy? Generalized lymphadenopathy means that there is involvement of more than 2 non-contiguous lymph node groups and is typically indicative of the systemic disease. Non-contiguous lymph node groups means not of the same group. For example, if 2 cervical lymph nodes are involved, then we don't say it is not non-contiguous, it is contiguous. Non-contiguous means cervical lymph node is involved, axillary lymph node is involved. So 2 or more than 2 non-contiguous lymph nodes are involved, then we say that it is generalized lymphadenopathy, and it indicates that there is a systemic disease. Now what is significant lymphadenopathy? Right, what is significant lymphadenopathy? We say significant lymphadenopathy on the basis of the size, fixity and its consistency. So when there are size of the inguinal lymph nodes, specifically for the inguinal lymph nodes, if the size of the lymph node is more than 2 cm, it is significant. So this is only for the inguinal region. let me be very clear about it, that for each region there is determined what is the size. For some reason any size of the lymphadenopathy if palpated is significant. For the inguinal region it is 2 centimeter. For extra inguinal region, other than inguinal region, every region more than 1 centimeter. But for these special areas, these are the 4 areas, in any size of these lymph nodes it is very significant. For example, supraclavicular, epitrochlear, popliteal, or any lymph node with a lesion in the draining area, if the lymph node is enlarged to any size, when it becomes palpable, then it is a significant lymph node, right? Based on the fixity, if the lymph nodes are fixed to each other, called as matting, seen in TB, and if it is fixed to the skin or fixed to the underlying tissues, then also it is a significant lymphadenopathy. And based on the consistency, if it is hard or firm lymph node, then also it is a very significant lymphadenopathy. So significant lymphadenopathy on the basis of size, fixity and consistency also. Now, what is persistent generalized lymphadenopathy? As we said, what was generalized lymphadenopathy? More than 2 lymph nodes, non-contiguous lymph nodes enlarged. But what is persistent generalized lymphadenopathy? It is defined as a condition where lymph nodes of more than 1 centimeter size in 2 or more areas persisting for 3 or more months is called persistent generalized lymphadenopathy. So, the mnemonic is 1, 2, 3. 1 means more than 1 centimeter in size, 2 means more than 2 in number, and 3 means for 3 or more months. It is basically seen in the HIV AIDS, right? It is seen in HIV. So, this is persistent generalized lymphadenopathy. Now, what are the causes of the generalized lymphadenopathy? The list is very long. You don't need to remember everyone, but just remember the important ones. For example, in the infectious causes, the bacterial, viral, parasitic and fungal causes are there. Just remember at least one from each. For example, in the bacterial, remember the TB, in the viral HIV, parasitic toxoplasmosis, fungal may any one of these. In the malignancy, most of the lymphomas, leukemia, CLL, all of them are causing the generalized lymphadenopathy. At least remember lymphoma and leukemias are there. In the immunological causes, you should remember about the SLE, then the JRA, juvenile rheumatoid arthritis, then the Kawasaki disease and the Sjogren's syndrome. At least you should remember these. In the granulomatous, remember about the sarcoidosis at least, endocrine hypothyroidism, and in the drugs, very important because the drugs are frequently asked, and in that also phenytoin, it causes pseudolymphoma, so phenytoin becomes very important. Along with it, you can remember other also, but at least remember the phenytoin one. Then we have syndromic lymphadenopathy, not very important, you can remember these or you can avoid them also. Now comes important point, that how we are supposed to describe a lymph node when it comes to the viva, or theoretically also it is important. So when you are asked that if you found any significant lymph nodes, then you have to tell the examiner, sir, that the size it is significant or not. You said there is a significant lymph node was palpated, then you tell about the site. In the inguinal region, how many you can tell about the number, more than 2 or 2 in the number. What was the consistency? If it was soft, it was hard, firm. If the overlying skin has any changes or not. If it is adherent to the skin or not. If the lymph node was mobile or not. If there is any tenderness or not, and how was the draining area. So you have to describe under these 8 points about a lymph node. So now coming to the consistency, we will describe the consistency a bit. Soft consistency is the normal consistency, which is soft. Malignancy may it is hard. Indian rubber type seen in Hodgkin's lymphoma. Shorty lymph nodes seen in syphilis. Then bubo. What is bubo? We always tell about the bubo in case of the sexually transmitted infections. LGV. In the LGV, we say that it is bubo type. What is bubo? Actually, it is a large lymph node with central necrosis is called bubo. Matted, very important, seen in tuberculosis due to periadenitis. All the lymph nodes, they get fused and form a single fused lymph node. This is called matted lymph node. Then we have hard lymph nodes in TB also, which is called hyperplastic tuberculosis lymphadenopathy. But at least remember the bubo, matted, hard and the soft consistency. What are these? These are the most important ones. Now comes the most important part, that how you should examine the lymph nodes and what are the different lymph nodes. See, there are many groups of the lymph nodes. Cervical is there, axillary, mesenteric, inguinal, paraiotic, epitrochlear. Then we have the popliteal. So all of these are there. But what is important, that what we are going to examine and which are the ones which are palpable. As you can see, the green ones you can see are palpable, like the inguinal, ones are examinal are palpable, then axillary is there, cervical is there. In these ones which are, you can see these are the non-palpable ones, these are the non-palpable ones, para-aortic is not palpable. So in the palpable part also you have to at least remember about the cervical and the axillary. Inguinal can be asked sometimes, but most important is cervical and axillary. Now we will understand what are the lymph nodes of the cervical region are and how to examine them. So first of all, we see that the cervical lymph nodes are divided into superficial or deep based on their position relative to the deep cervical fascia, and then also according to the position it is vertical or horizontal. So there are superficial cervical lymph nodes which are superficial to the deep cervical fascia, which includes the submental, submandibular, preauricular, postauricular, occipital. Then we have, these are all under the external Valdeir rings. Then we have pretracheal, paratracheal and posterior triangle lymph nodes. In the deep cervical lymph nodes, we have the horizontal ones which are the supraclavicular lymph nodes. In the vertical, we have the jugulodigastric and jugulo-omohyoid lymph nodes. But what is important to us is that these are all theoretically important, but when you are examining the patient and when you are answering into the viva, you are most importantly needing to remember the anterior and the posterior group of the lymph nodes of the cervical lymph nodes. This classification, that is anterior and then we have the posterior group, that is important when you are examining the patient. That is what is needed from you during the examination. So you will be asked to examine the patient, and that is where you will be checked that how you are examining the patient, how you are standing behind the patient or in the front of the patient. This is important. This is being noticed by the examiner, so do it carefully. So first of all, we examine the anterior lymph nodes, which is done by standing behind the patient. So what you will say, ask the patient to flex the neck, and then it will relax the fascia, and then start palpating the lymph nodes from standing behind the patient. So first of all, you will go for the submental lymph nodes using a single finger, right? You will use a single finger and palpate the submental lymph node, right? Then you will move on just in this way as it is written here. You will move on this manner only. First go for the submental group, then bilateral submandibular using both the hands, submandibular, then bilaterally preauricular, then jugulodigastric, jugulo-omohyoid, then supraclavicular lymph nodes using or with the pre or the and the paratracheal lymph nodes can be included or not be included, but at least till here you have to do and do it in this sequence only. So this is about the anterior group of the lymph node examination. Then we have the examination of the posterior group of the lymph nodes, and you have to do after coming in front of the patient, standing in front of the patient. So this is very, very important. Now start by feeling for the posterior auricular, then go for the occipital, then go for the posterior triangle group of lymph nodes. So here we see that there is the palpation of the cervical group of lymph nodes. So using both the hands, you are the examiner is examining the lymph nodes of the anterior triangle, then for the superior supraclavicular and then the posterior triangle from the front. Here you can see the patient, the examiner is standing in front of the patient and examining the posterior group of lymph nodes, that is the posterior triangle, as I have written here, by standing in front of the patient. Now we need to know the supraclavicular lymph nodes a bit because they are very much important, and what are the drainage of it. So the right supraclavicular lymph node is the drainage point for the right lung, all the three lobes, and the left lower lobe of the left lung, right? In the left supraclavicular lymph node, the left lung upper lobe is being drained, and the very important thing, 4 B's and gonads, breast, bronchus, bowel, bladder, all these are being drained in the left supraclavicular lymph node. That is why in the breast cancer also the left supraclavicular lymph node can be examined and it is enlarged. And also the gonads, that is the testis and ovary, also drains into the left supraclavicular lymph nodes. Then we have some important things here, as we can see, that is very confusing terms: Trousseau syndrome, Trousseau sign and Trousseau sign of tetany. So Trousseau sign of tetany you can appreciate in the hypocalcemia when there is carpopedal spasms. Trousseau syndrome is migratory thrombophlebitis seen in malignancies, and Trousseau sign is basically enlargement of the left supraclavicular lymph node, also known as the Virchow's node. So there are, as you can see, there are multiple names for the lymph nodes. The most important one is obviously the Virchow's node, which is the left supraclavicular lymph node, right? Other you can remember or you can avoid, no problem in that. Now we move on to the axillary group of the lymph nodes, and there are 5 axillary lymph node groups, and they include the lateral, anterior, also called the pectoral, then we have posterior or the subscapular, central and apical. And the apical is the final point for the all of the axillary lymph nodes. You have to at least the important one is the apical one, because it is the final common pathway. Also very important, note this, that examining the right axillary lymph nodes with the left hand except for humeral group, which is examined with the right hand. So if you are examining the right side of the axillary lymph node, examine it with the left hand, and if you are examining the right lymph node, left lymph node, examine it with the right hand, except for the lateral group, which you have to examine with the same side, that if you are examining for the right, do it with the right hand. Now drainage areas of the axillary lymph nodes, that is what are the sites that are being drained in the axillary lymph nodes. So the whole of the chest wall along with the breast is being drained by the axillary lymph nodes. Then the parietal pleura and the upper limbs are also being drained. Now what is the sequence, and this is very important for you to remember, that how you are going to examine the axillary lymph nodes. So now how to examine the right axillary lymph nodes. This is just an example, right or left, both are applicable. So first of all, you will have to ask the patient to hyper abduct the arm, here the right arm, hyper abduct the right arm. Then you have to place the right forearm of the patient on your left forearm, right, in the contralateral side. The right arm of the patient you have to examine. So you ask the patient to put his or her the right forearm on your left forearm. Then you have to insinuate your left hand fingertips in the deep of the axilla of the patient, and using the right hand of yours, you have to apply pressure over the patient's shoulder and feel for the apical lymph nodes using your left hand, right? You have to do this from your opposite hand. So first of all, you feel for the apical lymph nodes. Then below the apical, as you can see in this picture, as you are examining the right hand of the patient, you have to ask the patient to keep his or her forearm on your left hand, on your left shoulder. Then you, using your left hand, you put your hands, insinuate your hands into the deep into the axilla, looking for the apical group of the lymph nodes, and you put pressure on the right side of the shoulder with your right hand on the patient's body. Right. After that, going for feeling for the apical lymph nodes, you go for the central group of lymph nodes, which is just below the apical group, right? Which is just below the apical group. Then the anterior group can also be felt on the anterior axillary fold. Posterior group is felt on the posterior axillary fold, and the lateral group is palpated using your right hand. That is the side you are examining, do it with the same side of the hand by palpating over the patient's humerus. So this is the whole sequence in which you are supposed to examine the axillary lymph nodes. For the right or for the left, the sequence is the same, just change the right to the left and vice versa. So this is all about the axillary lymph node examination. We also have the epitrochlear lymph node examination, as you can see here, and the inguinal lymph node examination. So epitrochlear, let me tell you epitrochlear also. So epitrochlear group of lymph nodes are situated on the medial aspect of the elbow, about 4 to 5 cm above the humeral trochlea, and epitrochlear station drains the lymph from the last 2 to 3 fingers and from the medial aspect of the hands. So for examining the right elbow, ask the patient to rest the right elbow of the patient on the right hand of the examiner, as you can see here. So the elbow will be left, part of the left hand is being examined. So you ask the patient to rest the left elbow on your left hand, right, and feel the lymph node with thumb or by placing 3 fingers, and then you feel here, you feel with your thumb or the 3 fingers, right. So this way you can examine the epitrochlear group of lymph nodes. Now after we examine, we need to know if it is enlarged, then what could be the causes of the epitrochlear lymphadenopathy. So namely, they could be secondary syphilis, NHL, non-Hodgkin's lymphoma, HIV, disseminated TB, sporotrichosis, or it could be a cat scratch disease. So this is about the inguinal, this is about the epitrochlear lymph nodes. Then we have the examination of the popliteal and para-aortic. So para-aortic and popliteal not so important. Also the mesenteric is also not important, mediastinal is not very important. So this is all about the examination part of the lymph nodes. So lymphadenopathy is very important topic when it comes to the examination part. Most importantly is the cervical group of lymph nodes important when it asks for the examination, and the axillary lymph nodes. Epitrochlear may be asked or inguinal may be asked, but not so important. Most important is the cervical group of lymph nodes, very important. So this was all about this video. I have covered icterus, pallor, clubbing, lymphadenopathy, and the edema, and all these things. Next, in the next part, I will be discussing about the vitals, the BP, pulse, and all the important theoretical aspects of the vital signs, and what are their clinical correlation and how you are supposed to examine the patient. So this was all about this video. I hope you really like this video. If you have any confusion or any queries, you can write in the comment box, and subscribe to the channel for more such videos, and you can join my Telegram channel to get the PDF of this video. And also there's a lot of things, a lot of stuffs that I have uploaded here in the Telegram channel. You can check them out. So this was all about this video. I hope you enjoyed it, and stay tuned for the next part. Till then, have a good day. Thank you.